Hey everyone, I wanted to go through some topics on GI. Um, I was a GI nurse practitioner for a few years, so this is my jam. I really like GI. So I want to go through a few common things that we see. I could talk about this for hours, but I just picked a few common topics that we'll see. I have a couple of recorded lectures I did for nurses that are one's a CME credit about inflammatory bowel disease, so Crohn's and colitis. I'll post it. You don't have to watch it. It's just informative. If you want to watch it, you can, but you definitely don't have to. So I didn't include that in here because I have a whole lecture on those topics. So, and then I have another one about capsule endoscopy. It's a little bit detailed, so if you're curious, you're welcome to watch it. If not, don't worry about it. But I hope this helps you guys. So, hope you guys are all having a great week. Please, if there's any topics you're confused on, if there's anything you need, I want to help you guys understand everything. So please reach out to me. So with that, let's go ahead and get started. All right, so just briefly want to go over this because this is what we're going to be using when we document and we chart and when we talk to patients. So remember, there's these two systems that we use when we're talking about assessment of the GI system. And I'd say probably the more common one that's used is when we say right upper quadrant, it left upper quadrant, right lower, left lower. This system sort of divides the abdomen into four quadrants by this perpendicular line from the sternum to the pubic bone, and then there's a horizontal line across the abdomen. So this is important because if a patient comes in with left lower quadrant pain, there's certain things that we're going to think about. Oh, okay, well, diverticulitis is common with left lower quadrant pain. So if they come in with right upper quadrant pain, that's common in gallbladder disease. So there's certain areas that may trigger a thought, okay, this may be what's causing this. So it's a good system. And then the other system divides the abdomen into 9 regions, the epigastric area, the umbilical area, etc. And that also can be used, especially when charting. But typically, the one with the right upper, right lower, that one's used pretty frequently. So some important info we need to get from our patients, and I'm not going to go through this in total detail, but just remember we want to, when we're getting past medical history on our patients, we want to ask the patient, if they come in with a GI complaint, you want to ask about nausea, vomiting, abdominal pain, diarrhea, constipation, ask about abdominal distension and bloating. That's kind of a generalized thing, but definitely ask about that. Jaundice, anemia, heartburn, dyspepsia, changes in appetite. Are they vomiting any blood? Do they have any food intolerances or allergies? Indigestion, gas, lactose intolerance, melena. Are they seeing any blood in their stool, or is their stool black and tarry? Are they having any trouble swallowing? Do they have hemorrhoids, rectal bleeding? These are all important things. We also want to ask the patients, if they have any family history of any sort of GI issues. We're concerned about, a number of things. We also want to ask the patient about if they have a history themselves of reflux, gastritis, hepatitis, colitis, gallstones, peptic ulcer disease, cancer, diverticula, hernias. Have they had any unexplained weight loss? That can be concerning. And then, obviously we always want to remind our patients that they need their colonoscopy, depending on their situation, at typically every 5 to 10 years. So we always want to ask about, any GI related concerns or history. So for the physical exam, I'm sure this has been said a number of times, but I just want to reiterate it because I'm sure you're going to see a question like this on exams or boards, or this is just, I'm sure, going to be a question somewhere. There's no doubt. You always want to have good lighting when you're doing the abdominal exam. The patient's going to be in the supine position. They say to tell the patient to empty their bladder. In real life, that doesn't always happen, but for purposes of this, empty the bladder, warm your hands. The patient should be in the supine position, relaxed with the knees slightly flexed. Try to warm your hands so your hands aren't so cold. But the most important thing is that we think about what order we do the abdominal exam in, right? So this is a little different than the other exams that we do, but we're always going to inspect, then we auscultate, then we percuss, and then we palpate. So we're going to look at the abdomen for any skin changes. We're going to look at the umbilicus, make sure the abdomen is symmetric, see if there's any masses, if there's any movement. And then of course we auscultate before we percuss or we palpate to avoid altering bowel sounds. So if you palpate or percuss before you listen to the patient, then you may have these false sounds. So I'm sure you'll see this as a question somewhere. Always make sure that you auscultate before you percuss or palpate, because it may create false sounds. When we're auscultating, use the diaphragm of the stethoscope to auscultate the higher pitched bowel sounds and the bell for lower pitched bowel sounds. Notes say to warm the stethoscope to avoid abdominal muscle contractions. We want to listen for at least 2 minutes. So some terms that you may hear to describe bowel sounds, you may hear gurgling, rushing, high-pitched tinkling. You may have absent bowel sounds, which would be obviously concerning, increased bowel sounds or decreased bowel sounds. Also, listen for vascular sounds or an aortic bruit, and you shouldn't hear that. If you do, then that's an abnormal finding. Typically, it's an abnormal finding. And then percussing, you can use it to estimate the size of the liver, see if there's any fluid distension and masses. Palpate, of course. So light palpation is used to detect tenderness. Look for masses and swelling. Deep palpation is used to delineate abdominal organs and masses. So one-handed, you'll use the palmar surface of your fingers. Two-handed, fingers on the top hand, apply pressure to the bottom hand, which feels for the organs and the masses. So practice question, the nurse listens to bowel sounds for 60 seconds and she doesn't hear gurgling. What action should the nurse take next? So I'll let you guys read through that real quick. And the answer would be that we want to continue to listen for another 60 seconds, right? So we want to listen to bowel sounds for at least 2 minutes. If the bowel sounds are not heard, note the amount of time you listened in each quadrant. All right, so let's talk about the liver, and then we'll specifically talk about cirrhosis. A lot of my info I got from the Silvestri book, so it's a nice review book. I really like it. I'm sure you guys use it too. But let's review the liver. So remember, the liver is the largest gland in the body. It weighs about 3 to 4 pounds. It removes excess glucose in the body and amino acids from the portal blood, synthesizes glucose, amino acids, and fat. It aids in the digestion of fats, carbs, and proteins, stores and filters blood, stores vitamins A, D, and B, and iron. It secretes bile to emulsify fats. There are hepatic ducts that deliver bile to the gallbladder via the cystic duct, into the duodenum via the common bile duct. The common bile duct opens into the duodenum with the pancreatic duct at the ampulla vater. The sphincter prevents the reflux of intestinal contents into the common bile duct and the pancreatic duct. All right, so now that we talked a little bit about the normal liver, let's talk about cirrhosis. So cirrhosis is end-stage liver disease. So it's characterized by extensive degeneration and destruction of the liver cells. This results in the replacement of liver tissue by fibrosis, which is scar tissue, and these little nodules that occur from the liver's attempt to repair itself. So typically the development of cirrhosis, I'm sorry about my stuttering, happens after decades of chronic liver disease. This typically happens over time. It's not like this happens overnight. Patients may not know they have liver disease beforehand, but this is something that happens over time. It's not typically something that happens very quickly. So there are stages of liver disease. So there are a number of causes. So any chronic liver disease, including excessive alcohol intake, which is a very common cause, or non-alcoholic fatty liver disease can cause cirrhosis. Hepatitis C, hepatitis B. About 20% of patients with chronic hepatitis C and 10 to 20% of patients with those with chronic hepatitis B will develop cirrhosis. This happens. Chronic inflammation and cell necrosis from viral hepatitis can result in this progressive fibrosis and ultimately cirrhosis. There are some biliary causes of cirrhosis, primary biliary cirrhosis and primary sclerosing cholangitis. Primary sclerosing cholangitis is a chronic inflammatory condition that affects the liver and the bile ducts, frequently found in men. Cardiac cirrhosis includes a spectrum of hepatic issues that range from long-standing severe right-sided heart failure, causes venous congestion, cell damage, necrosis of the liver cells, and fibrosis. The cardiac cirrhosis treatment is aimed at managing the patient's underlying heart failure. So there are different stages. So you can see here we have our healthy liver, and then over time, for whatever reason, whether it's because of alcohol or hepatitis or one of these other causes that I talked about, the patient may develop fatty liver, and then the liver keeps trying to repair itself, and over time it becomes fibrotic, and you can see these little nodules that develop. And fibrosis, essentially what happens is this fibrosis develops, scar tissue develops, which leads to liver cell destruction, and then cirrhosis is the end stage, which is this chronic liver disease where this functional tissue that we once had is now replaced with fibrous tissue. So signs and symptoms of cirrhosis, obviously you can see there are a ton. So patients, like I said, patients may not be aware that they have liver issues early on in the disease. If a patient has just like a fatty liver, when I worked in GI, we were part of a research study, and they were doing a lot of research on non-alcoholic fatty liver disease. And there were so many patients out there that had NAFLD or non-alcoholic fatty liver disease that had no idea. So they had this liver disease, and it's beginning stages, but it's still concerning that they were unaware of. And if whatever the cause was, and a lot of times with non-alcoholic fatty liver disease, it's typically caused by obesity, diabetes, high cholesterol, that whole spectrum. If the patient, leads a healthier life and they lose weight, the thought is maybe it could be reversed. But a lot of patients were unaware they're living with this, and then over time it could progress. So it's concerning. But a lot of times patients may be unaware that they have a liver condition because there's really no symptoms early on. If they do have symptoms, it's very vague. They may have fatigue or an enlarged liver. When you have early stage liver disease, you may have some abnormal liver function, but blood tests may be normal. It may show normal liver function. Typically cirrhosis ends up being diagnosed later on when the patient has a lot of symptoms and they're in advanced, stage liver disease. The late manifestations typically result from liver failure and portal hypertension. Jaundice, peripheral edema, and ascites, these typically, I'll say, develop gradually. Other late manifestations may include skin lesions, hematologic disorders, endocrine disturbances, and peripheral neuropathies. So, like I was saying, in the advanced stages, the liver becomes small and nodular, and it just really isn't functioning well, and the liver function is dramatically diminished because of this. There's an overgrowth of